So the POLO trial, in one sentence, it proved the value of PARP inhibition in pancreatic cancer. It was a randomized trial. It was a global trial. It included screening more than 3,000 patients in order to find patients who are BRCA1 or 2 mutation. Those patients were initially treated with a platinum-based chemotherapy regimen, mostly with FOLFIRINOX. In fact, the vast majority got FOLFIRINOX because we knew that platinum compounds probably are more effective in the setting of the BRCA1 or 2 mutations, because BRCA1 or 2 mutations interfere with DNA repair, and platinum compounds produce DNA damage, and therefore the cell will be less able to repair them and therefore die. So in this trial, they had patients who received an initial induction period of chemotherapy, like 4 to 6 months, and the patients who really had a good response to the treatment or even stable disease then were randomized to receive either olaparib or placebo and continued on it until progression or they had major side effects. So that was the design of the trial. The primary endpoint was progression-free survival, and that was met. Overall survival remained the same whether you were on olaparib or placebo, but at least the progression-free survival was significantly prolonged, and it was prolonged to the extent that us clinicians will consider it clinically relevant and significant. It also did something else because it allowed us to have an option now in patients who are BRCA1 or 2 mutation to give them a period of chemotherapy, could be 4 months, 5 months, 6 months, maybe in future shorter, and then put them on what we call a maintenance treatment to avoid continuing with chemotherapy for a long time. Olaparib probably has less side effects than chemotherapy. It's more directed therapy, it's oral, so it's really an option we have for our patients. The future is to try to develop this concept further to see how we can now build on it to produce even improvement in survival in the long run.